Welcome back, everyone. Mabel Zhang here, and you're watching continuing live coverage of the World Healthcare Congress, coming to you from Washington, D.C. And now we're going to talk about prescription drug costs. And late last year, the Health Transformation Alliance took on these rising costs. In the studio now is CEO of the Health Transformation Alliance, Rob Andrews. Thank you so much for being here.
Mabel, it is always good to be back with you. Thank you.
Yes, and I believe it's your third time in our studio.
It's the charm, I hope, yes.
Now, tell me, how did you take on the issue of rising drug costs?
We took it on by asking the question that we think is most powerful and relevant, which is how can we make drug values rise? Price is important, but it's important in the context of what does the drug do for or to the health of the patient? So our members, 50 companies across the board, across the country, are focusing on that question. So if a person has multiple sclerosis and a drug succeeds in slowing the progression of that disease or succeeds in reducing the number of relapses, that's a very valuable drug to that person's health and economically. So we look at the question of cost in the context of total cost of care.
Okay. And you took on a partnership, too, to advance that idea, that agenda. We
do. We are working, of course, the main partnership is the 50 companies working together to share their data, to share their insight, to share their experiences. But with that partnership, we have also worked with Optum Rx and CVS to deliver the kind of care that I talked about a minute ago, to try to find a way that leads the physicians and care providers who treat our members to the right drug for the right value. The issue is not what does the drug cost. The issue is what good does it do? And is that good commensurate with the price?
Okay, but where do you begin to even figure out what the drug costs?
That's a great question. You think it would be obvious, it's not. But we begin with the data. We have the ability through our contracts to understand exactly what the rebates are, to whom they are passed through, what the retail discounts are and who's enjoying them, which then essentially permits us the ability to understand what the root cost of the drug is. So there is a black box in pharmaceutical. We are prying it open. Not for the purpose of combating or declaring war with anyone in the supply chain, but for the purpose of educating our members, their physicians, their care providers, and our employers about how much people are really paying for a drug. This is, I won't say it's unique in the US economy, but it sure is different or rare that you don't really know what the cost of something is that you're buying. We are assiduously trying to fix that problem.
Okay. What evidence do you have that you're making some progress in this area?
Yeah, two pieces of evidence. The first is that our members can now see what they are paying, and they can express their conclusions about what to do about that in the drug formulary. So beginning at the beginning of this calendar year, we work with our two partners to begin to revise the formularies, to incent the drugs that have the greatest value, and to begin to disincent or exclude those that have inferior value. So the meaning of that, of course, is that more of the 4.5 million members of the HTA are receiving the right drug at the right value. The second thing that we've been able to do is we've been able to look at the total cost of care for slices of that population and see whether it's improved. Now, it's very early on, Mabel, but our data from our first year of full operation, which was calendar 2018, shows that people who were in the HTA solutions had a significantly lower cost of care than people who were outside of the HTA solutions, meaning that more of them probably are getting the right drug for their care.
Are there drugs that you see over and over that people use that you're focused on in finding the most information you can about it?
There are. we've been able to generate lists of, let's say, the 20 or 50 most frequently used specialty drugs. We've been able to use public source information like ICER provides, and then information we are able to derive from the HTA database, and begin to draw conclusions about the relative efficacy or lack thereof of these drugs. These are all clinically controversial propositions, so we don't view this process lightly. But I guess we start from the proposition that in this economy, any product or any service should be subject to scrutiny that says, what's it really worth? What good does it do? And each of our 50 member companies is required to contribute its data to our database. So we now have a rich trove of information where we can answer questions like the ones you're asking.
Okay. Well, Rob, what is the message do you think you'd like to leave with our members about the work that you're doing?
Data works. If you have it, if you use it judiciously, if you understand the purpose of it, data is a game changer that lets you begin to understand how to discriminate between high value care and lower value care. So everything we do, Mabel, is about understanding that differentiation so people can be healthier.
All right. And how are you finding the conference?
I think it's great. I said this before, I will repeat it, that this is a really well-run conference. The people here are engaged, they're enthused, they're very deep in knowledge, and everyone I've interacted with here makes it a great experience. So I'm really happy to be back.
Rob Andrews, thank you so much for your
Thanks,
time.
Mabel.
We'll see you next year.
I sure hope so.
And I'm Mabel Jong. Thanks for tuning in.